everyone, as we come on YouTube. Great. Dr. Randall Gates, board certified chiropractic neurologist, also chiropractic physician at Gatesway to Health. Today we're talking about spinal cord disorders and syringomyelia. This is a special request from one of our listeners, so I thought it'd be good if we go into it. And we were joined by Kathy. Good morning, Kathy.
Good morning, everyone.
All right. So in talking about this topic, we're probably going to cover what is syringomyelia and who it affects and what causes it and all of that stuff. Just a little prelude. I've worked with a lot of patients in the past who have numbness and tingling and burning or weakness in their feet or their hands. Worked with a lot of patients who have had pain for a number of years. And pain is not always inflammatory. Kathy and I did a whole series on autoimmune conditions this year. And certainly inflammation can cause pain, but sometimes the pain is actually originating from the nervous system, from the spinal cord or the peripheral nerves. And so for a neurologist to be able to tease that out, or a functional neurologist, you have to go through a good diagnostic workup to really glean or figure out where the lesion is and what is causing the pain. So that's kind of what we're talking about today. Syringomyelia is not a common condition, but it is a condition that has to be considered in anyone presenting with chronic pain or odd symptoms that don't quite match what doctors would normally, think of as, okay, this is a standard pain pattern, because it kind of creates an atypical pain pattern. So any thoughts on your part, Kathy?
No, I have a couple, but I need you first to give us kind of a rundown of just exactly what it is.
Okay.
And how it affects patients, and then we'll come back with some other questions.
So here's our brain model. And then we have the brainstem down here. The brainstem continues as a tube, basically as the spinal cord. Now, if we were to take a section out of the spinal cord, I brought some visuals this morning, Kathy. I have a paper plate that I just drew on. And this would be like a transection of the spinal cord. Now, in this transection, I have this area that looks like an H. Well, to me, it looks like an H. And you see a little hole right there. That's called the central canal. So this H is the gray matter of your spinal cord. Gray matter is a familiar term. We have gray matter in our brain. Well, we have gray matter in our spinal cord. So this H area is the gray matter. That's where we have basically nerve cell bodies, if you want to think of it that way. Well, this little central canal here carries cerebrospinal fluid down the spinal cord. And if this central canal starts to swell and get bigger, that's syringomyelia. So basically, syringomyelia is a swelling of the central canal. Why is that important? It's important because as this little canal grows, it's going to push on tissue surrounding it. And if it becomes huge, it can actually push on most of the spinal cord. So in essence, think of your spinal cord. How do you think of it? It's like a dowel of wood, but then you have this hole that you drilled through the center of it for fluid to go down. And if there's excessive pressure within that fluid-filled canal is going to expand, and we call that syringomyelia. Does that make sense, Kathy?
Yes, it does.
Okay, good. Good. Perfect. Okay, so that's kind of what it is. Did I miss any other questions?
If we talk about some of the symptoms, we're looking about weakness and pain in the back and shoulders, arms and legs, inability to feel hot or cold, the loss of pain sensation, difficulty walking, bowel or bladder function problems, facial pain or numbness, and curvature of the spine or scoliosis. Is that about it?
I think that's a good summary.
Okay, here's my question.
Uh-huh.
And I guess it's kind of an age-related question, because a lot of these symptoms, a lot of older folks would just write off as old age.
Yes.
And not pay attention to, correct?
Correct. And that's why, on average, according to the textbook you read or the article you read, I think it's 3 to 4 years for a syringomyelia patient to get an accurate diagnosis.
Okay.
So from the time they present to their doctor saying, I have this pain, it takes them 3 to 4 years to be accurately diagnosed. I mean, that's pretty wild. It may be a little faster today in the era of, using MRIs a lot more frequently. But I think that pretty well says it. And the reason why is that syringomyelia, lots of times when it's starting, starts as just this weird nagging pain. It can be kind of a dull pain. It can then transform into like an ice pick like pain. And so patients are describing these things. They're like, doc, in my back, my mid back, right between the shoulder, doc, my mid back, it's like, it feels like I'm being stabbed by a knife, or I got this sharp pain, or it's just this nagging pain. And what are they going to do? They're going to be like, okay, you have pain. Let me give you anti-inflammatories, or let's send you to the physical therapist, things of that nature. When in reality, it can be syringomyelia creating that pain. How does it create that pain? Back to my diagram here, my lovely artistry. So looking at the transection of the spinal cord, for everybody who's joining, we talked about the spinal cord. Think of it as a dowel of wood, or a solid piece of wood with a hole in the center for fluid to go through. That hole is right here. It's called the central canal. Well, as the central canal expands, it hits this little line here. This is trying to represent a nerve pathway. Your pain nerves come in the back half of the spinal cord. They have a few synapses. There's a relay switch there to shut off the pain. And then it comes through the front part of the central canal. And so when the central canal swells, now it starts to hit these pain and temperature fibers. And that's where it's so important. And that's why patients start to get these nebulous symptoms of just the weird stuff like what you're mentioning, Kathy. And through time, it will become more characteristic. So it may just start in the mid-back, like I described, and then it may start to transform into an arm, basically the medial part of the arm commonly, one side of the chest and thorax. Then it's becoming more clear what's going on. Interestingly, though, a lot of patients and doctors would like to think, okay, well, if this is swelling, we should have symmetrical symptoms, meaning they should be the same on the right and left. And oftentimes they're not. Oftentimes as the central canal swells, it may swell to one side. And so you have more involvement on one side versus the other. So someone says, it's more my right arm. You get it. So that's kind of the presentation, so to speak.
Is there a main cause of it?
There are many different causes. So you mentioned scoliosis. Scoliosis can be associated with syringomyelia. Now, scoliosis patients, a lot of them have pain. Why? Because the biomechanics are different in their spine versus someone without scoliosis. But syringomyelia has a higher predilection or prevalence in scoliosis patients. Other conditions it's associated with include Arnold-Chiari Malformation. Arnold-Chiari Malformation is a common one. With Chiari, basically, here's your brain. Your brain sits in your skull. At the base of your skull, you have this hole. It's called the foramen magnum. Now, in some people, the cerebellum here, and I'm pointing to cerebellum for those of you on YouTube, the cerebellum can be pulled, and actually I better bring my camera down for you. The cerebellum can actually descend down below the foramen magnum, and that puts pressure on that area. Simply, there are specifics to this that I can go into, but basically think of your cerebellum coming through this hole, and then that pressure then can create more cerebrospinal fluid pressure, which can then create syringomyelia. Or think of this brainstem extending down through the spinal cord. If you have a tumor on the front of the spinal cord, which is affecting cerebrospinal fluid and its flow across the anterior portion of the cord, or if you have a tuberculosis infection from a vertebra extending back into the spinal canal, things like that, infections, tumors can also be associated with syringomyelia. Also, spinal cord shock. So somebody hits their head and they have shock in their spinal cord, or they're hit like this through this region. That spinal cord shock is also commonly associated with syringomyelia.
Okay, so what can be done for it?
Basically, what can be done for it is that they can, if it's very large, they can surgically repair syringomyelia and help patients there, or remove a tumor. There can be tumors that grow in the central canal, like ependymomas. So there are surgical procedures to help that. But in the neurology textbooks, they frequently talk about people who have surgeries and they may not be fully better. And we've worked with patients who have syringomyelia where they didn't have a surgery, but in working with them, we can actually work with the pain inhibitory pathways. At least that's theoretically what's going on as to our explanation of how they got better. Back here, there's a lot of evidence that through neuromodulation, you can come in and actually stimulate nerves here that function like a train track with the switches. So you can actually switch the pain reflexes from going through this anterior part of the spinal cord. It's always backward, everybody, so sorry. I'm not the best at doing that. So if we can stop these impulses from coming through, we may have a chance to help somebody with pain. Because if you took out a syrinx from the spinal cord and somebody still has horrible unrelenting pain, well, now there's a functional learning of that pain pattern. And that's where treating quote unquote central pain syndromes comes in from a natural standpoint. And that's what we've done. So.
Okay. Is there, I mean, if we do that and we don't surgically do anything, then the thing can still, is that going to cause more problems down the line? Or, I mean, I read where they could actually once in a while heal the cells that have kind of disappeared, dissipate, but, and others said it could like a shunt to drain the fluid or whatever. But if you're learning or like reforming these pathways or whatever, so the pain is kind of circumventing this. I mean, we're circumventing it, not causing the pain somehow. What's going to happen with that? I mean, if it's a cyst, it's going to continue to grow. So how are you going to handle that?
Not necessarily. So they don't always grow. And that's a really good point. So basically, a lot of patients, once they're discovered to have a syrinx, if it's not huge, if it's not really big, doctors will just watch and wait. So say, we don't really want to do anything right now. Let's just observe this. So they'll do MRIs every 6 months or a year to keep an eye on it. If it does grow, then Kathy, you're absolutely right. Then yes, a neurosurgeon needs to go in and basically take care of it. If it doesn't grow, then those are more the patients I've worked with who have Syringomyelia. And we've been able, with some of them, I'm not saying we have the cure for Syringomyelia. I'm just saying we've worked with some of them and they've had positive outcomes.
Okay.
Yeah.
All right, so we can do that. I'm just kind of wondering, I mean, we don't really know what causes it.
Well,
we said maybe a hit or an injury.
So basically, I probably didn't do a good job describing it. Typically, it's an increase in cerebrospinal fluid pressure that causes it. It can also just be quote unquote idiopathic. It can be, you know, people with scoliosis are more likely to have them. Sometimes they do just happen, but doctors have to be aware what else could be causing it. Like if you see Syringomyelia on an MRI scan, then you want to be thinking, do they have Arnold-Chiari Malformation? Because within this tube of your spinal cord here, coming down like this way, the spinal cord is bathed in cerebrospinal fluid. So it has this fluid insulation wrapped around it. Well, if your cerebellum is starting to come out of the foramen magnum, you have 3 layers of connective tissue, if you want to think of it that way, that's covering your nervous system, your brain, and your spinal cord. Well, the middle one, the arachnoid layer, can develop these things called arachnoid veils down here at the bottom of the skull, and then that prohibits adequate flow of cerebrospinal fluid, and then more pressure backs up, and that creates more pressure in the central canal. Same thing if you have a tumor at the front part of the spinal cord, same thing if you have an infection there, same thing if you've had an injury to the spinal cord. All those things affect fluid dynamics in that syrinx or that central canal.
So how common are these things?
They're not very common.
3 or 4 years to find. I'm guessing doctors don't see too many of them.
No, they're not super common. I can't remember the incidence. It's not very common. They're not very common, but they do happen. It's something you have to be aware of in neurological practice.
And easiest to find on an MRI?
Yeah, you find them on an MRI. An MRI then typically the cervical spine or involving the thoracic spine. Now, pain fibers from the head and the face, as I've talked about, descend down into the neck. So if you have one in your neck, lots of times it can actually affect the face, and that's called syringomyelia. But we had some questions last night. One that was forwarded to us was about idiopathic neuropathy. So when I listed this question, I said, you know, if you have numbness or tingling or burning or horrible pain, tune in. And one person said, well, what about idiopathic neuropathy? Because that has similar symptoms. And they're absolutely right. So with idiopathic neuropathy, think of it, let me grab another one of my paper plates here. Think of it as a pie. Half of idiopathic neuropathy patients have diabetes. The other half of the time, they have some other condition. About a third of this portion of the pie is due to pre-diabetes. That was discovered in 2001, validated basically heavily in 2008 and to present. Another third of the pie up here has gluten intolerances. Gluten intolerances create immune cells that attack our peripheral nerves, and that can create the symptoms of numbness, tingling, burning, et cetera, et cetera. Out here, you have a 10% population called monoclonal gammopathies. These are bone marrow disorders. Those can cause peripheral neuropathy. And then you have a host of other conditions that Kathy and I have talked about in other neuropathy broadcasts that can cause peripheral neuropathy. Anything from any liver or kidney condition. If you're critically ill and you're not breathing correctly, you have COPD. I mean, there's so many different things that cause neuropathy after that. But that's one element to be aware of. We had another patient, Kathy, who asked about B12 deficiencies. So B12 deficiencies certainly can cause damage to your peripheral nerves, namely in your feet. But a B12 deficiency also can affect your spinal cord, and it's called subacute degeneration of the spinal cord. Some people call it subacute combined degeneration of the spinal cord. Nonetheless, the lack of B12, because nerve tissue is heavily dependent on B12, the lack of B12 can create a syndrome where people have numbness and tingling frequently in their feet. Typically, they manifest with balance problems because B12 hits the nerve fibers that are very much affecting the position sense of our feet. And so that's something to also be aware of. If you think you have a B12 deficiency, don't just have your serum B12 checked. You want to make sure that the size, we lost Kathy. Let me call her back. Just give me 1 second. Hang on, everybody. Having a hard time reading through. So anyways, basically with B12 deficiencies, you want to make sure you get the size of your red blood cells checked. You also want to check things like homocysteine as well as methylmalonic acid. You also want to then think, why do you have a B12 deficiency? Are you not absorbing it from your stomach? Are you not absorbing it from your diet? Are you not breaking it down in your stomach? And conditions where the immune system attacks the stomach, autoimmune gastritis, pernicious anemia, those can cause deficiencies in B12.
Hello.
Hey, sorry we lost you.
Yeah, sorry.
Yeah, no worries. So basically, I just covered B12 deficiencies. And any other thoughts, Kathy, before I go to the next question?
No, I think that gave us a whole lot of information.
Okay.
Next question was, what do they do if they have it? And that kind of answered. We either leave it alone, or we do it your way, the natural way, or we have surgery, or do the shunt, or whatever.
Right.
I guess my other question was, does it make a difference in age? Is it more prevalent in older people? Does it show up in younger people? Does it make a difference?
It can show up in younger people, but generally I believe it's common between the ages of 30 and 70. So anywhere in that range, you can see something like Syringomyelia. I will say, I've seen patients of all age demographics within there. So I can't say it's more common in the elderly.
So do we have any other comments from listeners? We
do. So if the neuropathy is caused from prediabetes, once you have your diabetes under control, should the neuropathy stop getting worse? Good question. So if it's diabetes, probably not. I mean, I would say will it stop getting worse? Most likely, if you're able to get rid of your diabetes, the neuropathy progression is probably going to halt. If you have prediabetes causing neuropathy and you get rid of the prediabetes, there's a chance that your neuropathy will go away just with getting rid of your prediabetes. I mentioned it elsewhere, but all of you who have neuropathy and you don't have diabetes and you're in this other half down here of the non-diabetic group, you can't just have the standard blood tests done. You have to do an oral glucose tolerance test to really determine or make sure that you are fully evaluated for prediabetes. So you have to drink the 75 grams of glucose, sit at the lab, have them take your blood every half hour for at least 2 hours, and then we have to see what your blood sugar does. Because that study came out in 2001, actually from the University of Utah, where they saw all these patients with idiopathic neuropathy and they had a diabetic pattern, but their blood sugar was normal on a fasting glucose, their hemoglobin A1C, their 3-month measure of blood sugar was normal. And then they had them drink the glucose solution, and a huge percentage of them showed up being positive for prediabetes, and even 2 of them showed up for being positive for diabetes. I think it was out of 100 patients, like 36 were pre-diabetic and 2 were diabetic, something like that. So have an oral glucose tolerance test if you or if you know someone who has diabetes, or excuse me, neuropathy with an unknown cause. So yeah,
that makes sense.
yeah. So I think that pretty well covers it.
Yeah, I think we've learned a lot this morning. Thank you.
Okay, good. Yeah, thank you. And hello to everybody who joined us, and thank you so much for all the comments, and hope everybody's doing good all over the country, all over West Virginia. Lots of nice comments. So thank you, everyone. Appreciate it. Well, we'll be back next week with another topic. Any suggestions, we're open to it. We just did our traumatic brain injury series. Again, we're hoping to do some sort of recap of that. But if you have another topic that's really urgent, Kathy and I can talk about it, and we'll go from there. So thank you, Kathy.
Yeah, you're welcome.
Okay.
Bye, everybody.
Hi, everybody. Let me see here and live. There and there.